I am honored to introduce our alumni speaker, Dr. Geza Kish, Associate Professor of Anesthesia, Chief of the Acute Pain Service, and Head of Section of Orthopedic and Regional Anesthesia here at Robert Wood. Dr. Kish received his BA from Rutgers College in 1977 and his doctorate from New York Chiropractic College in 1981. He maintained a private practice in Middlesex County for 10 years before he came back to Robert Wood to receive his MD in 1995. He completed his residency and his pain fellowship here as well, and has been part of the faculty since. As second years, we've been delighted to have Dr. Kish as our lecturer over the course of the year. Although he jokes that his lectures are about putting people to sleep, Dr. Kish not only motivated medical students to get out of bed first thing in the morning, which, as we know, is not always an easy task, but he also kept us chuckling the entire time. We're thrilled that he has agreed to come here tonight to share his experiences, and I know we're in for an inspirational talk. And without further ado, Dr. Kish.
Hi. I think somebody's hijacked the remote. Aha. Okay. We working? Excellent. Sorry about that. So hi, everybody. Thank you for staying to listen to me ramble for however long I'm going to ramble. I'll try to keep it timely. Thank you also for finding a picture that made me look like Donald Trump, okay? That picture was taken maybe 10 years ago, and I said, I hope they find a pile of refuse to put it in, but no, somebody found it, and I'm really happy, and I guess it's not that bad. Anyway, so MedTalks, I think the acronym stands for Motivate, Educate, and Dream. I hope to give you a mildly entertaining diatribe. I thought of a couple of things a couple of titles, a couple of subjects that I was going to do for this, but I wanted to make it as broad as possible. So I said, brain surgery during the age of Charlemagne. I said, not really. The misunderstood prostate, friend or foe, but there's only like 10 men over the age of 50 out there, so how's that? Apologies to Kevin Smith from Jay and Silent Bob. I realized I came up with this title, and then I Googled it and found out he actually has a website by that name, so, but I have A in front of it, so there we go. My journey here is, everyone's journey is unique. Mine is a little different. I think that my personality is different, and it fits what I do. Now, if I can do anything tonight, it will be to share a few signposts. I'm going to go over a few sayings that I learned or heard in the past 30 some odd years, and each of those little sayings or adages or epigrams has a little story associated with it, but the commonality there is, number one, there is no black and white. There's not one message. There are many levels to each of the statements. And the other thing is, whenever I look at it, I say, why am I doing this? Everything I do every day is, especially clinically, is why am I doing a particular intervention? Why am I doing it in a particular way? For example, why am I here tonight? And it's the exorbitant amount of money that Sam said he was going to, right? What is it up to, 10 bucks? Okay, whatever. Let this just be food for thought, and after we can have real food. Chiropractic school, my first day, there I am, and the professor says, "This is what Hippocrates said, look to the spine for the cause of disease." And I knew a lot about chiropractic at that point, but I didn't realize that this professor was extremely philosophical and pretty zealous. And I looked at that and said, "Oh my God, what have I gotten into?" I said, maybe what they said about chiropractors and chiropractic is all true. And we won't talk about those truths because I'm going to make this a positive, a positive talk tonight. Nonetheless, chiropractic was invented in 1895. Dr. D.D. Palmer, I believe it was in Iowa. And it's basically about spinal manipulation. It came about 20 years after Dr. Still, who I think it was also in Iowa, if I'm not mistaken, started osteopathy, which was also a manipulative profession. That didn't come out right. A manipulative health discipline. There we go. And back in the 1890s, allopathic medicine wasn't what it is today. Until about 1919, when the Flexner Report was commissioned, where all the medical schools were standardized, curricula were standardized, treatment regimens were standardized. It was 1895 and you were going to the doctor, or worse, to the hospital, you probably weren't coming out because everything there was end-of-life care. There wasn't that much you could do in 1890. Nonetheless, osteopathy and chiropractic were very non-invasive. No drugs are given when you're a chiropractor. You give nutritional advice, you will educate patients regarding their health, but you don't give drugs. And I sat there for about 5 minutes and I said, okay, so what am I doing this year? I'm not doing anything. I might as well stay the whole year and see how it goes. And I was told, and I have told other people, don't quit. Stick it out for a little while. Just see how it goes. I have a daughter who wanted to quit swimming her first week. This really stinks. I hate it. I hate the water. And I said, stick it out for a month. 8 years later, she's a 5-time All-American. So I said, that's a good thing. Persevere. By the way, Laura Pierce is also a All-American swimmer, so she's out there. I wanted to let her know that I didn't forget about her either. Nonetheless, what did I learn in 10 years, 4 years of chiropractic school and 10 years of chiropractic practice? The body really does heal from within, no matter what anybody says. It is the substrate upon which we put our therapeutics that is the key. Look to the patients in the surgical intensive care unit who are victims of accidents, who are victims of other trauma, versus patients in other intensive care units in the hospital where, unfortunately, their homeostasis has given way to entropy. So always remember when you take care of your patients that Hippocrates said this too, it is far more important to know what person has the disease than what disease the person has. And I'm not going to oversimplify, but that says a lot. Another thing I learned when I was practicing was that there are many kinds of patients, but there are the helpless patients who need us a great deal. And then there are the patients who lack self-reliance. Until more patients in our population in this country learn self-reliance with our help, with our education, we're not going to be going in the right direction because you can't go to the doctor for every single thing all the time. Patients come in extremis, and then patients come in every week. If there are any docs out there, they know exactly what I'm talking about. We have to try and promote a more self-reliant patient population for those who can take care of themselves. And ultimately, why is medicine still in business? 2 reasons. Patients want to live longer and they want to be free of pain. If you can think of another reason, please get back to me. You can text me or email me, whatever. Off I went to med school 10 years after I had practiced, and I learned that which does not kill us makes us stronger, and you guys know that. Now, Friedrich Nietzsche was a great 19th century philosopher. He's a nihilist, which means he doesn't like a lot of things. I wasn't going to bring the picture, but there's a picture of him out in a street in Germany where he's trying to prevent a horse from being beaten because the handler was mistreating the horse. Unfortunately, that was the first manifestation of Nietzsche's bipolar disease, and from there he went downhill. But the creative ones usually have a little something else going for them. Nonetheless, he was a lot of fun at parties, I heard. It's, you know. I mention that which does not kill us makes us stronger because it's another example of substrate versus external force. We can exercise a great deal. We get hurt. We come back from it. That's great. But sometimes you push yourself to the point where you now have a chronic injury, and there goes your career. There are cases of post-traumatic stress disorder, which we all know about, of patients here who are dying from the catabolic stress response of surgery and trauma, and yet there are patients who seem to get better a great deal, and even better than where they were when they started, which is the concept of post-traumatic growth, which is a relatively new concept in the last 10 or 15 years. I mention it only because it's interesting. Look it up. If you haven't been taught it already, and it's a good possibility you have, but if you haven't, take a look at it. And once again, substrate versus external stressor. Now, med school's over. We survive. Sitting there, what am I going to do for residency? I have no idea. And I'm not going to take a show of, or try to ask for a show of hands like how many of you guys before third year really know what you're doing. In fact, the guys who are in fourth year, you're praying, well, I hope this residency I'm going into in 6 months is going to be okay. But I had no idea what I wanted to do. And I said, anesthesia sounds fun. I started going to the OR. I said, this is great. There's instant gratification. You push a drug, the heart rate goes up. You push another one, the heart rate goes down. You push another one, and they wake up. I said, this is really cool, okay? And then I said, why would I go into a profession where it is probably the most drug-invasive profession or specialty in medicine, where I came from the least invasive, least drug-addled part of healthcare. And I struggled. So what did I do? I took out the DSM-3R at that point. Now it's the DSM-5. And I started looking through. I said, nah, Axis 1, I think I'm okay. Keep going, keep going. Oh, Axis 2, okay. What would explain my desire to do this? Hypomania? Yes. No, that's not why. Okay, that may apply, but no, that's not the reason. Couldn't find it, and I just realized, I said, I really love it, period. It had nothing to do with my past history and trying to overcompensate for it. I said, this is fun. And when you guys pick your specialty, eventually, you'd better say to yourself, I really love doing this. Not like, oh, okay, I'll get by. I really love it. Most of you will find that eventually, but until you get there, don't settle for anything less. Something about that statement before about, oh, that's not what I said. This is the statement that I learned in residency. When you see food, eat it. When you see coffee, drink it. When you see a bed, sleep in it, okay? Now, I don't know who said that. It may have been Samuel Shem. I'm not sure if it was in House of God. It's actually, his name is Stephen Bergman. He's a psychiatrist, went to, I think he's a Harvard dude. And I couldn't find out who was responsible for this particular adage, but I think it was the unknown resident. I tried. I also realized that you guys are not going to be subject to the same rigors that residents 20 years ago, 25 years ago, and 30 years ago were under. And that's a good thing, because you can learn when you're awake. It's hard to learn when you're asleep. Nonetheless, there are, with a limitation, thanks to the ACGME, there are limitations to duty hours, and there should be. But just realize that when you become an attending, that sometimes you're going to be putting in longer hours as an attending than you were as a resident. So just keep that in the back of your mind. I mentioned this in class, but for those who haven't heard, anesthesia exists as a profession because without it, surgery really sucks. Okay, remember that. Pain fellowship. Why did I go into pain? Because I was a chiropractor and I thought I could take what I learned from chiropractic and apply it to my patients. And that's what I do. I still do acute pain now. And something I learned was narcotics are our friends. Now, that is Vincent DeAngelis. Vinny is an associate professor here. He's one of the finest human beings I know. He's one of the best anesthesiologists that I know. And he taught me that. He said he learned it in residency from some unnamed person, so I'll give him the credit for it. And what it says is that most people don't, they look at that and go, really? Okay, could I have a friend? And no, it doesn't work like that. Most docs are afraid to prescribe narcotics, period. And this is the only pitch I'll make through the whole evening. The curriculum in the United States for medical education has to change with respect to opioids. You've got people who are either extremely afraid and just dabble, or you have docs who just, yeah, sure, you want one, here's another script, thank you very much, here's some more OxyContin, and it leads to a problem, obviously. Now, narcotics applied in an acute situation, post-traumatic, post-surgery, they're fantastic. If you can temper it by combining it with a multimodal analgesic, so that you're using a regional anesthetic, so that you're using a non-opioid, you're using a non-steroidal, you're using a Tylenol, acetaminophen type drug, that's great. But once they get out of their acute situation, the American Academy of Neurology came out with a position paper about 5 months ago that basically said the risk of death, overdose, addiction, or serious side effects of opioids outweighs the benefits of chronic use in non-cancer patients. So that chronic low back pain, chronic anything pain that is not cancer, fibromyalgia, which I think they're going to find that it is a somatic manifestation of some psychiatric disease. You heard it here first. We'll see if that actually comes to fruition. But you can't be given it as an outpatient forever and ever. The regulatory system currently is less than perfect. When you write a script and the pharmacy has you on record and another doc writes a script for the same patient, and that's on record, and a third doc does it, and it's on record, but those three records don't come together, you have problems. And I will say that, and this hits close to home, a year and 2 weeks ago, lost my sister-in-law to that very thing. And Doc A, Doc B, Doc C didn't talk. OxyContin, 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 boom, 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 within a year, and it's unfortunate. It's got to change. With all the money that is going into healthcare now from on a national level, this has to be one of the priorities. And that's all the proselytizing I'm going to do about that. It's a matter of striking a balance between fear and complacency. Did I just do that? Thanks. Now here I am attending, and this is what I hear every day, not just in the OR, but up on the floors. We will do everything we can. Of course we will do everything we can. But when do you stop? 28% of all Medicare expenditure is on patients in their last 6 months of life, and you've heard this stat. 40% of all Medicare expenditure is on patients in their last month of life. And it's not the doc's fault. They're not out there trying to just rake in the bucks before a patient goes. That's not what happens. Yeah, grandma had a stroke. Yeah, well, do everything you can for her. When was the last time you saw grandma? I don't know, about 4 months ago, maybe 5. Have you talked to her? No. Do you communicate with her? No, but I'm her power of attorney, so just do everything you can. When grandma maybe did not want that. Or let's do the same thing for a patient, and instead of talking to the patient and saying, maybe this surgery is not good for you because the risk of the surgery is greater than the benefit. Not picking on surgeons, the risk of the medical intervention is greater than the benefit. And what has to be done is communication. And until that happens, you're going to have this be a problem. Death panels aside, I'm not getting into the politics of that. That's a third rail. But patients, families, and doctors have to talk. It's plain and simple. Finally, as you leave tonight, try to remember this. Oh, that's me. Take your job very seriously. Don't take yourself seriously. Develop a sense of humor. If you don't have one, go buy one. Go take a course. There's gene therapy for almost everything. I'm sure there will be something for that soon. That's number one. Number two, don't be annoying. Just think about it, okay? That's from a friend of mine, another physician, but don't be annoying. Thirdly, always put yourself in the position of the patient. Before you're going to do something for or to the patient, say, what would I want? Or what would a friend or family, if that were a friend, close friend or family member, would I want to do that to them? Always remember that. And finally, never stop asking yourself why. Thank you.